Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of an elderly man, 80-year-old male, who presented to our ER with complaints of generalized weakness since about 2 days. So there was this 80-year-old male, sir, who presented to our hospital with complaints of generalized tiredness since about 2 days. He was evaluated at a local hospital, diagnosed to have hyponatremia, and we got the patient with suspected hyponatremia evaluation. So in our initial 10-second assessment, patient was drowsy but arousable and confused. He was not obeying commands as such. Airway-wise, airway was patent, but no secretions were seen, no anatomical deformities were noted. Breathing-wise, patient had air entry to be bilaterally equal, but he was tachypneic with a respiratory rate of 31-32 cycles per minute, but SpO2 was 86% in room air. Along with this, circulation wise, he had low BP of 80/60 and a heart rate of 96 cycles per minute, and all peripheral pulses were palpable but feeble. So with this, disability wise, he had a GCS of E3V2M5 and pupils were 2.5 mm bilaterally reactive to light. Exposure wise, he had a temperature of 98.6 degree Fahrenheit and GRBS was also normal, 85 milligram per deciliter. So with this, we concluded that the patient was tachypneic, so he had some respiratory component involved. Along with this, he was hypotensive with a BP of 80/60.
Is he a diabetic patient?
He is a diabetic patient.
Okay. 83 is normal in a diabetic patient.
So,
what happens to the patient?
It will be masked, and besides, this patient was also on beta blockers, so that could have been the reason for his low heart rate.
I'm not asking that. In normal person, 83 also, they may not feel hypoglycemic symptoms. But a patient who is having chronically diabetes, if the sugars are even normal, they can have even symptoms of hypoglycemia because always their sugars are very high level. So they may have a blood sugar level of 140, 150 always. Okay. Now suddenly, even if it is normal now, 83, there also he can have symptoms of hypoglycemia because it's a relative hypoglycemia for that patient. But it is normal. In lab wise, it is normal, but patient can have relative hypoglycemic symptoms.
So at this juncture, we took as a primary adjunct, we went ahead with ECG, sir. ECG showed, first ECG that was taken showed LBBB features. Okay. LBBB features meaning the patient will have a white complex QRS that will be more than 120 milliseconds, and then patient will have S waves in V1, and there will be W pattern in there will be slurring of that. So they'll have W pattern in the lateral leads. Not the lateral leads, the
W
V1
pattern,
leads.
it can be M pattern or W pattern. It can be sometimes positive, it can be negative. Most of the time it is positive, M pattern. Then following this M pattern in V6 or W pattern in V6, what is the next thing? What happens to the ST segment T waves?
ST segments?
Depression over V5.
So this will be discordant. Discordant means if it is M pattern in V5, V6, ST will be depressed and T wave will be inverted. Whereas if it is W pattern, ST will be elevated and T will be upright. This is called as discordant pattern. If both are in same direction, then we have to be very careful because that is one of the criteria for acute myocardial infarction. Okay, concordance in V5, V6. And so how here it is concordant or discordant?
Discordant.
Okay, but one of the ECG was concordant.
The subsequent ECGs. So then this was a new onset.
There is a wide complex tachycardia here. Is it regular or irregular?
It was an irregular tachycardia, sir.
So what are the differential diagnoses for irregular wide complex tachycardia?
There are certain DDs. It can be most common will be an AF with an aberrancy, like underlying any bundle branch block with an AF, or WPW syndrome with AF can present as a wide complex irregular tachycardia. Along with this, the other DDs can be a polymorphic VT, and when a patient is in arrest, you'll have to think of VF.
Okay. So yeah, when it is irregular, we have to always think about atrial fibrillation with LBVB or RBVB. Okay, wide complex tachycardia, which is irregular. If it is regular, then it is mostly because of VT or SVT. Again, SVT with aberrancy.
So at this point we have ABG was also taken. ABG showed a pH of 7.39 with a PCO2 of 43.3.
What pH abnormalities or acid base abnormalities can present with arrhythmias? Which type of acid base? Acidosis or alkalosis?
The arrhythmias
Alkalosis with hyperglycemia.
Commonly, you are seeing acidosis
Acidosis
is commonly
is
associated with most of the arrhythmias, not alkalosis. Alkalosis is only when it is associated with hypokalemia and all it can produce. But acidosis is mostly
it will trigger the arrhythmias. So pH is 7.39, PCO2 43.3 with a bicarbonate of 26.2 and a lactate of 1.4. But the thing is this. So at this point, 2 large IV bore cannulas were placed, and then in view of low BP, we gave a fluid challenge and then started the patient on NORAD because repeat BP was only about like 160. And then this ECG finding of a new onset LBBB was a new finding. So new onset LBBB has to point towards MI.
In this patient?
86.
86.
So new onset LBBB has to be thought about in terms of myocardial infarction. So the cardio team was also involved in this patient's management.
Cardiac enzymes?
Cardiac enzymes, although were not much elevated.
Okay. So
CKMB
then what do you think? Cardiac enzymes are not elevated. Patient is having tachycardia, wide complex tachycardia. That too it is LBB pattern. What it is called as? It is not MI, it is not having any ischemic heart disease, but rate is high, LBB is there.
It can be just a trigger from an underlying patient's condition.
It is rate related LBB, rate dependent LBB. That is one of the common problems we will face in emergency room because when the rate increases, sometimes you can get LBB pattern in ECG. Okay, so it can be simply due to the rate itself, but there may be an underlying problem in the heart that we don't know, but if you control the rate, it may revert back.
So then CKMB and TROP-T were not that elevated. So myocardial infarction was taken off.
Why in LBB we are sending CKMB and TROP-T?
Because new onset LBBB denotes MI, sir. Okay. So
LBB always indicate ischemic heart disease. New onset LBB always indicate acute coronary syndrome. In that acute coronary syndrome, one of the syndrome is myocardial infarction.
So that was ruled out because cardiac enzymes are not that elevated. But then apart from the management of the ECG bit, the patient's breathing pattern was, since he was tachypneic and saturation wasn't maintaining, effortful breathing, labored breathing. So we put the patient on BiPAP also. Okay. And then the tachypnea.
What may be the one of the relative contraindication in this patient for BiPAP?
If the patient is drowsy, drop in sensorium.
He's not drowsy, no? He's drowsy.
He was drowsy but arousable.
Anything else? BP?
BP is the positive pressure ventilation can further worsen patient's hypotension.
If you don't circulation part here, sometimes patient can develop hypertension only because of your NIV. Okay. So you have to be very careful.
So the patient was started on an inotropic support, then breathing wise
What all inotropic supports you can give here?
So one, because the patient is not tachycardic and this is perhaps a cardiogenic shock with an underlying septic shock.
But how do you know that it is cardiogenic shock? Echo is done?
Echo was done, sir.
BNP is done?
Pro-BNP wasn't done because echo showed septal motion which was consistent with LBBB. Okay. Along with this, patient had a concentric LVH, but there was no evidence of any RWMA. So it was all attributed to his underlying sepsis condition, which we will be eventually finding out.
Fluid is the first choice. If there is no cardiac failure, fluid is the first choice.
And then upon auscultation of this patient, we found that the patient had crepitations. In view of low sensorium, aspiration pneumonia was also suspected because bedside point of care CBC-CRP that we did had elevated counts of about 20,800 as total counts, with the CRP being more than 230.
Okay.
So the hypertension was
Can myocardial
perhaps...
infarction elevate all these things?
It can, sir, because
Can also elevate. Counts can be elevated,
it's
CRP
an
can be
inflammatory marker rather than infective markers, so it can be
elevated.
attributed.
Procalcitonin?
Procalcitonin was 3.75.
So it's a local infection. It's not a sepsis, but he is having hypotension.
Yeah.
Okay.
So then, with this, type 1 respiratory failure was corrected with the oxygen supplementation and put on NIV, and then for circulation management, fluids was given, following which patient was put on inotropic support, and after this he became hemodynamically stable, but the ECG continued to show AF with aberrancy. So the patient was cardioverted. In view of instability, 150 joules was given as a cardioversion dose, and following this the rhythm reverted to sinus rhythm, and then it continued to remain so. It never patient never developed any dysrhythmias.
The BP is good. What other drug you can give?
Patient can be given with amiodarone.
What is the dose?
Amiodarone, if the patient's BP is good, then loading dose can be given of 150 mg followed by 1 mg.
150 mg
over the span of 15 to 15 minutes.
150 milligram over 10 minutes.
Over 10 minutes.
That is a dose.
Then followed by 1 mg per minute over for the next 6 hours. Then 0.5 mg per minute for 18
hours. Or you can give start after
8 hours and 16 hours.
Then
in
you
total
can start
24 hours.
oral tablets. Okay.
So amiodarone can also be an alternative, but because this patient was hypotensive, we cardioverted in view of instability, and sinus rhythm was achieved. Then after this, he never had any cardiac dysrhythmias. So our next priority was to treat. But
LBB persisted?
LBB reverted.
LBB also reverted. So it is mostly a rate dependent.
Rate dependent. So probably secondary to his underlying sepsis condition. Aspiration pneumonia was what was suspected, and X-ray portable was taken, which showed consolidation. Actually, the consolidation was both in the right and the left side, but predominantly it was on the left side of in this patient.
Okay.
But generally, aspiration is more common in the right side because of more horizontal bifurcation.
But that depends on patient position. If the patient is always on left-sided decubitus position, then he can have left-sided also.
So then upon when we sent for lab investigations, all his dyselectrolemias like hyperphosphatemia, hypomagnesemia, hypokalemia, all of that was corrected in this patient. Perhaps which is why, and we started this patient on an empirical antibiotic therapy covering both gram-negative bacteria and also gram-positive, along with atypical coverage. So we started the patient
Why are you thinking about atypical bacteria here?
Elderly age, low immunity. So
what else?
Atypical.
Second hospital is visiting.
That is not atypical. Atypical is community acquired. Hospital acquired is different.
A diabetic patient, low immunity, elderly.
Sodium?
Sodium 132.3.
Okay. Normally when you have prolonged symptoms or less symptoms, hyponatremia, hemolysis, altered behavior, then all these things are you are suspecting more of atypical. No high degree fever means mostly it is atypical. Normally typical pneumonia will have high degree fever, cough, breathlessness, sputum production, blood tinged sputum, all these things will be. If that is not there, you suspect atypical or aspiration pneumonia like you told. What antibiotic you started? We started the patient on piperacillin tazobactam along with clindamycin combination. Piptaz was given in the dose of 4.5 gram TID, and clindamycin was given 600 mg TID dose. But during our daily monitoring of lab investigations, he was found to have increasing CRP. That's when we changed or rather hiked up the antibiotic from piptaz tazobactam to meropenem. So now the patient continued to be on meropenem and clindamycin combination, and then blood cultures came back to be positive for gram-negative bacilli, and sensitivity was like for Enterobacter cloacae complex bacteria was found out.
but that was sensitive to meropenem. So we just continued the patient on meropenem, and serially the patient's CRP and total count started to decrease, and clinically also he improved. So BiPAP was slowly taken off, like spaced as 1:6, and then taken off NIV support. And inotropes like NORAD, the patient that he was on, also was tapered and stopped. Then and then his sensorium did not really improve much, sir. He was not obeying commands, he was still confused. So then
what are the electrolyte imbalance can produce altered behavior?
Altered behavior, hyponatremia can cause, hypoglycemia can cause.
Hypoglycemia is not electrolyte imbalance, but it can produce.
Can cause, or that's about it. Potassium, magnesium doesn't cause. No.
Magnesium can produce. Potassium can produce altered behavior in which condition?
The
hepatic encephalopathy. So almost all calcium can produce. Hypercalcemia or hypocalcemia can produce. Hypophosphatemia can produce some amount, but not like hyponatremia. So hyponatremia is the most important thing. Ultimately, what happened to the arrhythmia?
Arrhythmia resolved. We cardioverted the patient. Following this, he never had any cardiac rhythm abnormal disturbances.
So here the problem is how to manage a wide complex tachycardia. How do you manage a wide complex tachycardia in ER?
Wide complex tachycardia, we'll have to first see whether the patient condition is stable or unstable. If the patient's condition is depending on that, and then the next thing that we have to ask
patient is unstable.
Unstable,
what
it will
are
be
the conditions you
cardioversion.
call it is unstable?
One patient should have hypotension or altered sensorium or any features of heart failure, any ongoing chest pain.
Okay, all are considered as
signs of
instability. Then how do you manage?
If it is like that, then we'll have to go with cardioversion, that is synchronized cardioversion, wherein we deliver the shock in sync with the R wave of the rhythm. So we'll have to turn on the sync button in the defibrillator, the cardiac monitor, and the machine itself will sync the
first positive wave.
Yeah, first positive wave. And then we'll have to, it is just like cardioversion, wherein we'll first give, in terms of placement of the lead.
How do you give shock?
I will sedate the patient first. Take consent, explain the procedure and
consent, sedate, then?
Then when we place it, we'll have to keep it hold it for a couple of seconds, like about 5 seconds before we withdraw it.
Okay, so you have to wait for some more time because machine has to deliver the shock. Okay, whenever you press, it will not deliver. First, when you get the positive R wave, it will deliver. So you have to keep little more time. It is other way. Suppose
if
it is stable.
Then we'll have to look whether the rhythm is regular or irregular. And if it is regular wide complex tachycardia, then it is more likely a VT, or it is SVT with aberrancy. So
what are the aberrancies?
Aberrancies like it can be with an underlying WPW syndrome. Basically, aberrancy means just something that is abnormal, like an reattenant pathway.
Aberrant pathway or aberrancy like LBV, RBV or WPW syndrome. Any aberrancy can produce wide complex. Okay, so you get wide complex tachycardia in that. Okay, but it is regular. Irregular means?
If it is irregular, then it will be AF with aberrancy or a polymorphic VT, or that torsades point is because of prolonged QTC interval, and otherwise it can be, if the patient is in arrest, it is VF.
Okay, normally VF patterns are different. A VT pattern is different. Okay.
So accordingly we manage. If it is AF with aberrancy, then we can start the patient on amiodarone.
Regular wide complex tachycardia, how do you manage?
If it is regular, then we'll have to see whether it is with aberrancy or if it is a VT. And if it is a stable VT, then we can start with amiodarone. Again, 150 mg bolus we can give with infusion rates. Or if it is SVT also, we can...
SVT with aberrancy also we can give amiodarone. But if you know that the problem, then suppose it is LBV or RPV, can still go for other drugs. What are the other drugs?
So the
beta blockers, diltiazem, verapamil. Okay.
So basically, wide complex, any wide complex we can initially go with rate control.
Okay.
Any beta blockers or diltiazem we can.
Only thing is if it is due to WPW syndrome,
verapamil has to be.
Sometimes it can create problem. Okay. Otherwise, you can try any drug.
Then with in irregular bit, AF with aberrancy can be again treated with amiodarone infusion itself, or if it is a polymorphic VT or a torsatic pointers, magnesium sulfate 2 gram IV can be given in order to treat it.
Okay.
VF, it is anyway the patient is in arrest, so we go straight with the defibrillator.
Okay. So the rate is normally can get controlled with your DC shock, but LBB or RBB getting corrected with shock is very, very unusual. So here you have to think that this is mostly because of sepsis induced tachycardia and tachycardia induced LBB, and hypoxemia may be contributing for atrial fibrillation. It all created a misdiagnosis actually. It is not, may not be a MI at all.
MI. The only
Because
thing,
if you go according to Scarbosa criteria, it is MI because concordance pattern is there, but even then cardiac enzymes are not elevated.
yeah, the only thing that was against the whole diagnosis of MI was non-elevation of cardiac enzymes.
But in emergency room, the main treatment of tachycardia is to control the rate. Whatever may be your available resources, you have to control the rate. So you have to control the rate with DC cardioversion.
That's about it, sir. He actually even CT brain was taken because of an elderly patient, drowsy, low sensorium, in order to rule out any IC bleed. CT brain was also normal. That's when we were attributing it to the probably underlying sepsis and metabolic NKF.
Okay.
And hypoxia itself can cause low sensorium.
Okay. Do you suspect prolonged hypoglycemia in this patient?
Possible, sir.
He is taking any insulin?
He is a known case of diabetes, hypertension, vascular dementia with a past history of PCA infarct in 2019 and hypothyroidism. So he was on hypoglycemic agents like glycomet, and then Thyronorm he was taking for his thyroid issues.
Do you think that it is a hypothyroid problem?
He didn't seem to have other issues.
I am only asking one question. Do you think that it is due to missed tablets of thyroid?
Initial DD can be considered, sir. Like myxedema.
Bradycardia.
Present with bradycardia. If it is due to hypothyroidism induced coma, suppose many patients can miss the thyroid tablet, elderly individual, those who are sick. But if there is no bradycardia, then clinically you cannot make a hypothyroid coma. Okay, but even then you have to send the investigation. TSH has to be done. TSH is done?
Yeah, TFT was normal.
Normal. Okay.
Then other than that, no other issues. So during our course of stay in his hospital, he improved, sir. But he continues to remain, like his sensorium is not
broad.
Completely, 15 on 15 GCS hasn't been achieved yet. Okay. So he's still getting treatment.
So these are findings of prolonged hypoglycemia, prolonged hypoxemia. All these things can have prolonged altered behavior in elderly individuals. So we have to suspect that it's because he is having aspiration pneumonia. So hypoglycemia can induce aspiration pneumonia. That can induce hypoxemia. That can produce all these problems. So we don't know what triggered the problem, but all these things should be corrected. Can MRI will pick up hypoglycemic brain injury?
That encephalopathy features can be picked up. That can be picked up.
Hypoxemic changes, ischemic changes can be picked up by only MRI, not by CT. So ideally after 48 to 72 hours you have to take a MRI to see what is the prognosis of the patient. Okay, it will not give any diagnostic help, but prognosis we can predict. Okay, anything else?
We can instead of amiodarone we can also go for lidocaine.
Lidocaine.
Okay. 1.5 to 1 mg to 1.5. Because in ACLS also we are actually replacing that with.
But it is not a first line drug, no?
No, not a first line drug.
No, amiodarone is not available.
Not reporting or effective.
Okay, second line drug. Okay.
Thank you.